It's a 35-year-old female with a known case of infective endocarditis. Okay, and with mitral valve replacement at childhood age. Now she is presented with low-grade fever, vomiting, and seizure episode. The CT scan shows the following findings. It shows a well-defined ring enhanced lesion with a surrounding edema. Okay, but the patient is having low-grade fever, vomiting, and seizure episode. There is various reasons for the ring enhancing lesions. Various differential diagnoses are there. When the patient presents with the fever, vomiting, and seizure episodes with some side effect or mass effect, you have to think of the diagnosis, cerebral abscess. So, what are the various etiological causes for the cerebral abscess? Okay, cerebral abscess most of the cases is spread from the hematogenous spread. Okay. Okay, whenever there is a patient having a sinus or mastoid infection, okay, whenever the hematogenous spread, and whenever there is a penetrating trauma, food contamination, and immunocompromise. Okay, so the most common organism for the sinus or mastoid infection is the streptococci. Okay, bacterioids, enterobacteria, staphylococcus, and the pseudomonas. Whenever the hematogenous spread is there, the main causative organism is bacterioids. Okay, the Staph aureus is mainly responsible for the penetrating trauma and the Clostridium species and Bacillus enterobacteriae, and food contamination by the Toxoplasma, okay, and the neurocysticercosis. In immunocompromised patients, HIV and toxoplasmosis, okay, and the Cryptococcus fungi and JC virus are responsible for the cerebral abscess. What is the treatment of the cerebral abscess? You have to go for early drainage of the abscess, followed by you have to use antibiotics for cultural sensitivity. Okay. So, early drainage of the abscess is very important. So, when you are suspecting, okay, of cerebral abscess, you have to do immediate drainage of the abscess by using the cultural sensitivity of the pus. You have to start antibiotic, high empirical antibiotic. Okay. Next, 55-year-old female, hypertensive. She is hypertensive and presented with a severe headache. Okay, and multiple episodes of vomiting, seizure, nuchal rigidity, and cranial nerve palsy. Okay, and the CT scans shows the following findings. So, what does the CT scan shows? It shows hyperdensities in the sulcal spaces. Okay, all the sulcal space hyperdensity is there, and the cistern is full of blood. Okay, it's full of hyperintensities. It shows that the patient is having diagnosis subarachnoid hemorrhage. Okay. So, you have noticed the hyperintensities all around the sulcal spaces, cisternal spaces. So, it is indicative of subarachnoid hemorrhage. The diagnosis is subarachnoid hemorrhage. So, what is the various causes for this condition? Risk factors, clinical grading, gold standard investigations, radiological grading, management, complications, and how to prevent vasospasm in this patient. Okay. So, the diagnosis is subarachnoid hemorrhage. The various causes of subarachnoid hemorrhage is spontaneous ICH. Okay. So, the various risk factors for subarachnoid hemorrhage, number one is age and female sex, hypertension, smoking, cocaine use, and a family history with 2 first-degree relatives affected. Okay. Among these, the female sex and hypertension as very important risk factors for the development of subarachnoid hemorrhage. What are the genetic disorders predisposes to the condition is? One is adult polycystic kidney disease and FMD, okay, fibromuscular dysplasia, NF1, Ehlers-Danlos, and Marfan syndromes. What are the various grades? What are the various clinical grades and the CT scan grading to assess the subarachnoid hemorrhage? The clinical grade is Hunt-Hess grading and WFNS grading. The clinical grading by Hunt-Hess, WFNS clinical grading. Okay, what Hunt-Hess clinical grading? It has 5 grades. Okay, the WFNS also having 5 grades. Okay, what is Hunt-Hess grade 1? When the patient is asymptomatic or minimal headache or slight nuchal rigidity, the grade is 1. And whenever the patient is having moderate to severe headache, nuchal rigidity, and with or without cranial nerve palsy, the grade is 2. And whenever the patient is drowsy, confusion, or mild focal deficit, the grade is 3. Whenever the patient is in stupor, moderate to severe hemiparesis, possibly early decerebrate rigidity, the score is 4. Whenever the patient is in deep coma and decerebrate rigidity or moribund, the grade is 5. Okay, these are the 5 grades, okay, for the severity of the symptoms presented to the patient. Okay, from grade 1 to 5, the one is asymptomatic to deep coma, the grade is 5. Okay, and in WFNS grading, they are using only GCS and motor deficits. Okay, based upon the GCS and motor deficit of the patient, you can assess the WFNS grading for the SAH. So, grade 1, the GCS is 15 with no deficit, and the grade 2 is 13 to 14 without deficit, and the grade 3 is same GCS 13 to 14 with the deficit. Okay, so the GCS 13 to 14 without deficit is grade 2, the grade 3 is the GCS 13 to 14 with the deficit. Okay, and the grade 4 is GCS 7 to 12 with or without the deficit, and the grade 5 is GCS less than 7. That means that 3 to 6. When the patient presents 3 to 6, the grade 5. So, the WFNS grading, so the grade 5 is 3 to 6 and the with or without deficit, and the grade 4 is 7 to 12 with or without deficit, and the 3 is 13 to 14 with the deficit, and the 2 is 13 to 14 without deficit, and the 1 is 15 without deficit. Okay. The totally 5 grades for the clinical grading. The 2 different types of grading is one is Hunt-Hess and WFNS grading. What the gold standard investigation of choice for subarachnoid hemorrhage is digital subtraction angiography. Okay, digital subtraction angiography. It's a gold standard diagnosis, investigation of choice. And what is the CT grading? CT scan grading for subarachnoid hemorrhage is defined by the Fisher. That is Fisher grading. Okay. Fisher grading, it has 4 grades. Grade 1, there is no hemorrhage. Okay. Grade 2, diffuse SAH with vertical layers less than 1 millimeter thickness. Okay. The vertical layer will be 1 millimeter thickness. Okay. Another 3 is localized clots, or the vertical layer is more than 1 centimeter thick. Okay. And the grade 4 is diffuse or no SAH, but with the ICH or IVH. Okay. So, there is 4 grades for Fisher. Fisher 1, 2, 3, 4. The Fisher 1 is no hemorrhage at all, and the grade 2 is diffuse SAH with the vertical layer less than 1 mm of thickness, and the 3 is localized clot, okay, or vertical layer more than 1 mm of thickness, and the grade 4 is diffuse or no SAH, but with the intracerebral IVH. Okay. Next, what is the treatment for SAH? Okay. Either you can go for open surgery or endovascular technique. So, in open technique, craniotomy, the option is clipping. The endovascular option is coiling. It is a basic idea. Okay. So, this diagram shows the patient's presence with the perianeurysm from the distal ICA, the distal ICA aneurysm where it is clipped. Okay. And this is another DSA image that shows the patients having aneurysm, basilar top aneurysm. Okay, basilar top aneurysm where it is coiled. Okay. Okay. So, how to prevent the vasospasm? Suppose the aneurysm has ruptured. Okay. So, the vessel will more prone for the vasospasm, and it leads to the ischemia for the particular site that the blood supply giving. Okay. So, you have to prevent or treat the vasospasm. So, what is how to prevent arterial narrowing? By doing subarachnoid blood removal. Okay. That is, we have to put our temporary external ventricular drain, because the blood itself is a irritable material that will cause vasoconstrictions. So, you have to remove the subarachnoid space space blood collection as much as possible by giving by putting an external ventricular drain, or prevention of dehydration and hypotension. For that, adequate fluid resuscitation should be given, IV fluids, okay, and calcium channel blockers, okay, is nimodipine, tablet nimodipine should be given. This is 30, the tablet nimodipine 30 milligram, and you have to give for every 4th hourly, okay, 2 tablets every 4th hourly, or the total dosage is tablet nimodipine 60 milligram, okay, every 4th hourly you have to give, okay. And how to reverse arterial narrowing. Suppose arterial narrowing has already happened, so how to reverse? This means you have to go for intra-arterial calcium channel blockers or transluminal balloon angioplasty, okay. So the triple S therapy, hypertension, hypervolemia, or hemodilution. So you have to prevention of arterial narrowing, you have to go for subarachnoid blood removal, prevention of dehydration, hypotension, calcium channel blocker, tablet nimodipine 60 milligram 4th hourly, and for the reversal of arterial narrowing, you have to go for the intra-arterial calcium channel blockers infusion, or we can do balloon angioplasties. And for the prevention and reversal of ischemic neurological deficit, you have to do triple S therapy. Okay, what is the 3H? Maintaining hypertension, hypervolemia, and hemodilution. Next question is, these are the various points of subarachnoid hemorrhage. Okay, subarachnoid hemorrhage, various risk factors and genetic disorders. What are the clinical gradings? Hunt-Hess, WFNS grading, and gold standard investigations in DSA, or the CT grading, treatment options, and how to prevent and treat the vasospasm. Next, 55-year-old female patient presented with a headache, multiple episodes of seizure with the right-sided weakness. Okay, the radiologic investigation shows the following. This is a 3D reconstruction of a CT angiography, okay, that shows the vessels becomes very entangled, okay, okay, the crowding of the vessels is seen in one side in CT angiography 3D reconstruction. In MRI, okay, you have noticed the multiple flow voids, okay, multiple flow voids can be seen in T2 MRI, and this is a DSA image, okay, that shows multiple entanglement of the vessels, okay, in one area, okay. It shows that the patient is suffering from AVM, okay, arteriovenous malformation. So what is the grading for AVM? It is a Spencer-Morton grading. Okay, the Spencer-Morton grading is useful in clinical judgment. Okay, and the treatment. What are the options of the treatment? Okay, to be taken for AVM. Spencer-Morton grading. It has 3 features. One is nidus size. Okay, number second is elegance of the brain, where the AVM is present. It is elegant or non-elegant. Third, a pattern of venous drainage. Okay. Number 1 is nidus size. It is less than 3, the point is 1. If it is 3 to 6, the point is 2. If it is more than 6, the point is 3. And the eloquence of the brain, if it is eloquent means it is a very reachable area. That is an important area. Okay, it's called eloquent. Okay, the eloquent is very important area. Okay, that is not able to reach via surgery. Okay, it is very useful for the primary functions of the day-to-day activities. Okay, that is the eloquent area. Okay, so suppose the AVM is present in the non-eloquent area, the point is 0. Eloquent area, that is sensory motor, language, visual, thalamus, hypothalamus, IC region, brainstem, cerebellar peduncle, okay, or deep cerebral veins. These are the areas called as eloquent. The point for this eloquent AVM is 1. Okay, and the pattern of venous drainage is superficial or deep drainage. Okay, only superficial, it is 0, and is deep venous drainage also present, it is 1. Based upon the score, okay, you have to grading the AVM. Okay, so what are the various options for treatment of AVM? Okay, so you have to go for craniotomy with the surgical excision of the AVM. Okay, so in case of the patient's grade is 1 or 2, okay, if the grade 3 or 4, you have to go for embolization only. Okay, And there is option of SRS. SRS, stereostatic surgery, radiosurgery, if the lesion is less than 2.5 centimeter in diameter. Okay. So, main surgical options, we have to do craniotomy and excision of the AVM, even if the grade is very small, 1, 2. Okay. For the grade 3, 4, you have to go for endovascular technique of embolization. In case if the AVM is less than 2.5 centimeter, you can go for SRS also. These are the AVM, gradings of the AVM based upon the nidus size, elegance of the adjacent brain. Next is third component is whether venous drainage is superficial or deep. Okay, based upon this, you have multiple treatment options. A 25-year-old male, okay, while playing cricket without helmet, okay, he experienced a hit by a ball on the head region. Following the patient developed periorbital. Following a week, the patient developed periorbital swelling with the proptosis. Periorbital swelling with the proptosis and scleral edema. Okay, these are the features. And this CT angiography, it shows the following findings. Okay, what is the diagnosis? Okay, you see mainly in the cavernous region, you have seen the there is a abnormalities of the venous structures. Okay. Okay, and this you have to see in coronal section, you have to see the dilatation of the superior ophthalmic vein. Okay, it indicates that what is the diagnosis of this patient, what are the reasons behind this formation of this condition, and what are the various treatment options. Okay, this is a case scenario. So the patient is suffering from carotid-cavernous fistula. Okay. Carotid-cavernous fistula. The reason behind this, the internal carotid artery, this passes through the carotid cavernous sinus. Okay, it's communicating with the superior ophthalmic vein, pituitary sinus or spinoparietal sinus. Okay, so whenever the ICA goes via the cavernous sinus, it have connection with the superior ophthalmic vein. Okay, and pituitary sinus. Okay, this is also present in the cavernous sinus because of the trauma. The trauma leads to the tear in the carotid vertebral artery. Okay, at the tethering point passing through the skull and leading to fistula with the surrounding venous plexus. Okay. Okay, here the carotid artery having fistulous connection with the superior ophthalmic vein. That's why there is a dilatation of the superior ophthalmic vein, followed by the patient developed periorbital edema and proptosis also. Okay, because of this abnormal communication between the internal carotid artery and the superior ophthalmic vein. So, how to investigate this patient? The pre-op investigation is doing ocular pressure measurement, especially by tonometry. Okay, if it is very high, we can go on urgent basis. The treatment should be on urgent basis. Okay, number second is the MRI. It shows the dilatation of the superior ophthalmic vein. This is characteristics of carotid-cavernous fistula. So, most of this patient will go treated by endovascular technique, by like you have to block the fistula by using embolic material or coil or detachable balloon. Okay, to occlude the venous side of the fistula. Okay, this is a case of carotid-cavernous fistula. There is abnormal communication between the internal carotid artery with the superior ophthalmic vein. So MRI shows the dilatation of superior ophthalmic vein. So endovascular technique to occlude the fistula, especially venous side, by using embolic material, coil or detachable balloons. A case scenario of a 10-year-old female child, okay, is going to school and is presented to the OPD with a severe headache, seizure, okay, on and off, and he is having poor scholastic performance. Okay, his academic performance is very poor. Okay, and evaluation, okay, on further scans, finally angiographs shows the following findings. Okay, so what is the diagnosis, pathogenesis and the types, and angiographic appearance, and what is the treatment? Okay, so as you all knows, this angiography shows look like a smoke-like appearance, puff of smoke-like appearance. So it's called diagnosis myomeia disease, and it is mainly due to the progressive obliteration of one or both ICA with the development of external carotid collaterals. Okay, these are two types, juvenile type and adult type. Okay, and the angiographic finding is proposed smoke appearance. What is the mainstay of management? So we have to connect the external carotid circulation with the internal carotid circulation. So ECA to ICA bypass. Okay, you have to take a branch of ECA, that is a superior temporal artery, okay, superficial temporal artery with the middle cerebral artery. Okay, so you have to connect STA with the MCA. Okay, superficial temporal artery with the middle cerebral artery branches. Okay, that is the mainstay of management for Moya disease. Next, a 65-year-old male presented with a headache, seizure, vomiting, and left-sided weakness. Here, MRI scan shows the following findings. It shows like a ring-enhancing lesion. Okay, it shows a well-defined, okay, ring-enhancing lesion. Okay, so what is the diagnosis? And the generalized, what is the generalized classification of brain SOL? The various presentations belongs to the various regions of the brain. What is the treatment of the above condition and chemotherapy of choice? Okay, this obviously no, it is a very high ring enhanced lesion. Okay, and it is having some heterogeneous mass inside the cavity, and it's having very mass effect and midline shift. Okay, it belongs to glioblastoma multiforme. Okay, the diagnosis is glioblastoma multiforme, the most common primary tumor, okay, of adult. Okay, glioblastoma multiforme. Okay, so it belongs to grade 4, WHO grade 4. What are the other classifications? This is not a WHO classification, it's a generalized classification of brain SOL. Okay, so the brain tumor, what is the most common brain tumor is metastasis. Okay, so metastasis is the most common brain tumor. Following, other than that, based upon the site of cells of origin, it have pituitary tumors. Okay, and it have tumor-like malformations. In that, craniopharyngioma, colloid cyst, and dermoid epidermoid cyst. Okay, and in extraaxial, it has meningioma and vestibular schwannoma, and in germ cell tumors, wherever the neuroepithelial component, it has pineal region tumors, and in gliomas, neuronal tumors, medulloblastomas. In the gliomas, again divided into oligodendrogliomas, astrocytomas, ependymoma, or choroid plexus tumors. Okay, it is the overall classification of the brain tumors. Okay, so it is a neuroepithelial or tumor-like malformations, or pituitary, cellular SOL, or metastasis, or extraaxial. You can classify it. What are various chromosomal abnormalities associated with the brain tumors? Okay, so neurofibromatosis 1, NF1, NF2, Cowden's disease, HNPCC, and LF, Leaf-Romani syndromes. Okay, what are the various genes affected and tumor associated with these syndromes? Okay, so in that, all of the tumors are associated with the astrocytomas. Okay, a variant of glioma, except NF2 is not associated with the astrocytoma. It is associated with the aquastic neuroma, that is bilateral aquastic neuroma. Okay, with the meningioma. Okay, bilateral aquastic neuroma and meningioma. So NF1 is a main gene involved in the chromosome 17, neurofibromin gene. It's present in the chromosome 17, and the tumor involved is astrocytoma and neurofibroma. And NF2, the main gene defect in the schwannomin gene, it's present in the chromosome 22. Okay, 2 for 22, 2. Okay, and it is having two tumors, that is bilateral CP angle SOL, that is aquastic neuromas, and Cowden's disease is DEN, and Cowden is P10, 10. Okay, DEN 10, 10. You remember like this, Cowden is a P10 chromosome, a P10 gene defect present in the chromosome 10, and the main tumor involved is astrocytomas, and HNPCC, multiple genes are involved. Okay, and its main tumor is astrocytoma, and Leaf-Romani syndromes, the P53 gene defect is there, present in the chromosome 17, is astrocytoma. And what are the various patterns of deficits associated with the tumor based on the location? Suppose the tumor location is the pituitary, the most common pituitary tumor is pituitary adenoma. The patient present with the bitemporal hemianopia and gaze paralysis. In case of CP angle Especially the most common is vestibular schwannomas. The patient present with the hearing loss, balance disturbances, tinnitus. This is a triad. Okay, this is a triad of CPI vestibular schwannoma. Okay, the patient present with the hearing loss, balance disturbances, tinnitus. So anterior skull base tumors, example olfactory groove meningioma, is presented with a syndrome called Foster-Kennedy syndrome. The Foster-Kennedy syndrome is associated with the anosmia, ipsilateral optic atrophy, or contralateral papilledema. It is called Foster-Kennedy syndrome. Okay, so anosmia, ipsilateral optic atrophy, and contralateral papilledema. Okay, it is because of the involvement of the olfactory groove in the side only. They is having this optic nerve also. Because of this, the patient developed anosmia, ipsilateral optic atrophy, the contralateral papilledema. Okay, due to the venous obstructions, called Foster-Kennedy syndrome. And the occipital region like glioma, the patient present with the homonymous hemianopia with the central sparing. Okay, homonymous hemianopia with the central sparing. The parietal region, especially the dominant hemisphere, the patient present with the Gressman syndrome. The Gressman syndrome is the acalculia, agraphia, right to left disorientation, and finger agnosia. This is called Gressman syndrome. It is present in the parietal region, especially on the dominant hemisphere. Third, parietal region, non-dominant. The patient present with the dressing apraxia, astereognosis, and sensory inattention. In the temporal region, the patient present with the memory disturbances, contralateral superior quadrant anopia, and dysphagia. Okay. Okay. So the superior quadrant, the contralateral superior quadrant anopia is called pie in sky. Okay. Okay. So memory disturbances, contralateral superior quadrant anopia, and dysphagia. Especially if the dominant hemisphere is involved, the patient will have dysphagia. Okay, the patient suffer from Wernicke's aphasia also sometimes. And the frontal region is mainly for the, suppose the patient having glioma in the frontal region, the patient develop personality changes, gait disturbances, and urinary incontinence. Okay, in brainstem, the patient will have multiple cranial deficits, long tract sign, and nystagmus. In posterior fossa, the patient present with ataxia or hydrocephalus. The management is multimodality management in all SOL, especially in glioma, which is shown in the above picture. The patient needs gross total resection with the postoperative adjuvant therapy like chemo with radiotherapy. So, what is the chemotherapy drug of choice for these patients is the temozolomide. Okay, the temozolomide is the current chemotherapy drug of choice for the high-grade gliomas. So, the patient present with the GBM, there is an overall classification of tumors and the chromosome associated with the brain tumors, and these are the pattern of deficit. Okay, in that pituitary region will have bitemporal hemianopia, a CMP angle having its own triad, and there is an olfactory groove meningioma source, Foster-Kennedy syndrome, and is a parietal region SOL with the dominant hemisphere source, Gressman syndrome, and especially in the temporal region, dominant hemisphere, the patient having dysphagia. Brainstem will show multiple craniopalacies. The management is a multimodality management. Chemotherapy drug of choice for high-grade glioma is the temozolomide. Next, a 75-year-old male presented with a severe headache for 3 months with a left-sided lower limb weakness. The MRI shows the following image. Okay, so this MRI sagittal view shows a well-defined lesion. Okay, it shows a well-defined. So, okay, ISO to hyperintense lesion. Okay, it's ISO to hyperintense lesion, which shows a typical finding attached to the dura, and it shows a typical finding of a dural tail. Okay, attached to the dural tail, and is especially seen in the mid region, mid sagittal region, and the fox. Okay, mid region, and which shows the corpus. This is the corpus callosum. Okay, and this tumor is thought to be arising from the fox region. Okay, which is separating the two parts of the brain. Okay, so the diagnosis to be the fox meningioma. Okay, these are the MRI characteristics of the MRI features characteristics of the meningioma. Is a dural tail. Okay, it's confined to the dura. Okay, so what is the diagnosis? What is the grading of meningioma? Okay, what is the characteristics finding of meningioma on CT or MRI? What is mother-in-law sign? What are the various treatment options? What are the indication for post-operative radiotherapy in case of meningioma? So this is the diagnosis to be a Fox meningioma. The grading is, we have two gradings. One is based upon the macroscopic removal of the tumor. So we have to grade the meningioma after removal of the tumor only. Okay. On CT, MRI, we cannot grade the meningioma. Okay. Especially meningioma, we have to grade after removal of the tumor. Okay, how much we are removing the tumor, based on that we have to grade that meningioma, and we can assess the recurrence rate of that meningioma, okay, based upon the grade. Okay, grading based on the macroscopic removal is called a Simpson's grading. The Simpsons having 5 grades, grade 1, 2, 3, 4, 5. So grade 1 is macroscopically complete tumor removal, okay, with the excision of a dura and abnormal bone. So 3 are removed. Okay, so tumor also removed, dura also removed, bone also removed. That means that this is grade 1. Okay, so grade 2 is the tumor is removed and is coagulated the dura. Dura is only coagulated. Okay, so tumor removed and the dura is coagulated. That is, we cauterized the dura, not removed the dura. Okay, so 3 is complete removal of the tumor, okay, or only cauterize the dura. Okay, the grade 4 is subtotal removal, not totally removed the dura. Okay, and the grade 5 is simple decompression. Okay, we not at all touched the tumor. Okay, we only did the decompression only. Okay, so what is grade 0? The grade 0 is we have to remove tumor also, dura also, bone also, and in the bone also we have to take a surrounding 2 centimeter margin. 2 centimeter margin of the bone also we have to remove. Okay, that is called grade 0. Grade 1 is tumor, dura and bone. Grade 2 is tumor with the dura. Okay. Grade 3 is tumor without cauterization of the dura mater. Only cauterized the dura mater. And 4 is subtotal removal, and 5 is simply decompression. Based on the microscopic removal, we have modified Shinsu grade, okay, and Akudera Koyabashi grade, okay. Okay, modified Shinsu grade and Akudera Koyabashi grade. It having 5 grades, grade 1, 2, 3AB, 4AB and 4. Okay, so grade 1 is complete microscopic removal of the tumor, okay, and dural attachment with any abnormal bone. Okay, this also having tumor, dura and bone. Okay, and grade 2 is same, microscopic removal of the tumor with the diathermic coagulation of dura. Only coagulated the dura. Okay, and 3AB, okay, the complete microscopic removal of intradural extradural tumor, okay, without resection or coagulation of its dural attachment. We didn't touch the dura, that is 3A. Okay, 3B is complete microscopic removal of intradural tumor, okay, without resection or coagulation of its dural attachment or any other extradural. Okay, the 3A is removed both intradural and extradural, but in 3B removed only intradural. Okay, the 4A is intentional subtotal removal. Okay, subtotal removal of the tumor to preserve cranial nerves or blood vessels or the complete microscopic removal of dural attachments. 4B is partial removal. Okay, partial removal of the tumor, leaving tumor less than 10%. If you leave the tumor more than 10% of the volume, that is called grade 5. It is called modified Shinsu grade or Akudera Koyabashi grade. okay, based upon the microscopic level. Based on the microscopic removal, the Simpson's grading system is used. What are the characteristic finding of meningioma on CT or MRI? So it shows the meningioma shows a broad base of attachment to the meninges. Okay, and it also shows the characteristic dural tail, what I have shown before in the MRI. So dural tail, then hyperostosis is seen in the CT also. CT, where you see a hyperostosis. Okay, and you see the edema around surrounding that meningioma, and a well-defined enhancement will be seen. Okay, as shown in this picture. So what is called mother-in-law sign, which is specific for the meningioma. So the mother-in-law sign is nothing but it is seen mainly in the angiography finding. It is seen in the CT angiography, okay, or DSA. So mainly in the CT angiography, which is while giving the dye, it appears yearly in the arterial phase, but it persists beyond the venous phase. Okay, but it still persists beyond the venous phase. Come yearly and persist till late. Okay, that means that like a mother-in-law, they come to the home yearly and stays late. Okay, okay, in simple words, they are telling that it as mother-in-law sign. Okay, so the various treatment options for the meningioma. So it is asymptomatic. The meningioma is asymptomatic, just wait and watchful. And other treatment options are surgery by craniotomy, excision of the meningioma. Okay, for that only we have advised the two grades. Okay, macroscopic and microscopic gradings, Simpson's and modified Okapishi grading, and radiation therapy, and MRI guided laser interstitial thermal therapy, LITT, and focused ultrasound therapy. These are various options. So what is the role of a post-operative radiotherapy in case of meningioma? Okay, so it is indicated in based upon the HPA report. The HPA report suppose shows it is anaplastic variant. Okay, belongs to WHO grade, WHO grade 3. Regardless of the extent of resection, you have to give radiotherapy. Number 1 is anaplastic, and number 2 is new atypical meningioma. Okay, new atypical meningioma belong to WHO grade 2 with a subtotal resection. That is belong to Simpson's grade 4 or 5. Okay, so anaplastic, new atypical, Simpson's grade 4 or 5. Okay, and recurrent atypical. In case of recurrent atypical meningioma also you have to give radiotherapy. So 3 indications only. One is anaplastic variant, second is a new atypical meningioma, and third is a recurrent atypical meningioma. So the meningioma, this MRI shows dural tail. So what is Simpson's grading based on the macroscopic removal? Based on the microscopic removal, modified Sinhu or Akudara Koyabishi skin, and characteristic finding on CT and MRI, mother-in-law sign. There is treatment options, indication of post-operative therapy. A 26-year-old, next is a 26-year-old unmarried female presented with a milky discharge from the nipples, bilateral nipples, and amenorrhea. Okay, and she also having visual abnormalities. Ophthal findings, that is visual field chart. Okay, the field chart and MRI is given below. Based on what is the diagnosis of the patient. Okay, so the MRI shows T1 weighted MRI which shows enhancing lesion. Okay, cellular in the cellular or supracellular region, a mass in the cellular or supracellular region is shown. Okay, so it is a case of cellular supracellular SOL that is extending into the cavernous sinus. So based upon the history, okay, the patient having milky discharge and amenorrhea, it should be a functioning, okay, pituitary lesion. Okay, especially goes in favor of functional pituitary macroadenoma. Since the size is very high, okay, it should be a functional pituitary macroadenoma. So what is the diagnosis? What are the various differential diagnoses? There is a classification based on imaging. What are the baseline investigations? What are the prolactin levels? Prolactin levels that is useful for the management. What are the treatment options available? What are the indication for transcranial approach? What is pituitary apoplexy? So diagnosis is a cellular or supracellular SOL, especially it is a functioning pituitary adenoma, that is prolactinoma, is based upon the clinical scenario. is otherwise called amenorrhea and galactorrhea syndrome, okay, also known as Forbes-Albright syndrome. Okay, it's a common clinical scenario that is seen in the neurosurgery OPD. What is the differential diagnosis of the cellular SOL based upon the tumor of adenohypophyseal origin? It can be pituitary adenoma or neuronal choriostoma or pituitary carcinoma. Okay, based on the tumor of neurohypophyseal posterior pituitary, it can be granular cell tumor, pituitary-cytoma, spindle cell oncocytoma, or astrocytoma of posterior lobe. Okay, tumors of non-pituitary origin can be craniopharyngioma, germ cell tumor, glioma, meningioma, chordoma. The rare tumors of non-pituitary origin can be chordoma, esthesioneuroblastoma, giant cell tumor of the bone, okay, and glomangioma, hemangiopericytoma, lipoma, lipomyosarcoma, lymphoma, meningioma, myxoma, paraganglioma, post-radiation neoplasm, rhabdomyosarcoma, sarcoma, schwannoma. In the cyst or hamartomas, malformations, Rathke's cleft cyst, arachnoid cyst, epidermoid cyst, dermoid cyst, empty cell syndrome. The metastatic tumors, it can be carcinoma, plasmacytoma, lymphoma, leukemia. Inflammatory conditions like pyogenic infections, granulomatous infection, mucocele, sarcoidosis, Langerhans, Wegener. In the Rosendorfen disease and giant cell representative granuloma. Vascular lesions like sacral aneurysm, intracavernous carotid, supraclinoid carotid, and anterior communicating anticomplex or basilar tip and cavernous angiomas. Among these, the most common differential diagnosis for cellular masses, number 1 is pituitary adenoma, okay, craniopharyngioma, meningioma, okay, and Rathke's cleft cyst, arachnoid cyst. These are the most common differential diagnosis for cellular SOL according to incidence wise. Based upon the size of the tumor, it can be divided into microadenoma, which is less than 10 mm in size and is present incidentally with the endocrine effects. Okay, may present as incidentally or it's having endocrine effects like functioning like tumors. And macroadenoma, it should be more than 10 mm and is having visual field deficit. Okay, based upon the functional, non-functional, the non-functional is 20%. Among the functioning, prolactinoma is 30%, 15% is secrete GH secreting hormones like acromegaly, gigantism, and 10% secretes ACTH. Okay, classification, another classification based upon the anatomy or extension of the tumor or invasion or spread it to the floor of the cell, spina extension, distant spread, classified as a modified RD system. So, modified RD system based upon the extension. So, based upon the extension, it having supracellular or paracellular extensions. It is graded as A, B, C, D, E. So, A is extended to the supracellular systems, and B to the recess of the third ventricle, and C is the whole of the third ventricle, third of the anterior third ventricle. Okay, it extends. Okay, so this is extensions, and the paracellular, the D is maybe intracranial, intradural, either anterior, midline, or posterior. Okay, or extracranial, extradural. Okay, lateral cavernous sinus. That is called E. Okay, so the A is supracellular system. Number B is extends up to the recess of third ventricle, and the C is whole of anterior third ventricle, and the D is intracranial, intradural, and the E is extracranial, extradural. And based on the invasion or spread, can divide into 5 grades. One is cella normal or focally expanded less than 10 mm, and 2 is cella enlarged tumor more than 10 mm, and based upon the sphenoid extension. Okay, if we extend to the sphenoid, it is called 3 or 4. It's localized perforation of the cellular floor and diffuse destruction. A distant spread with the CSF or bloodborne is 5. Okay, it is given in this diagrammatic representation. Okay, so grade 1 or 2 is within the cella. Okay, within the floor of the cella. Floor of the cella is intact in case of grade 1 and 2. Okay, if it is beyond the floor and invaded the sphenoid sinus, it is grade 3 or 4. So, the grade 3, the floor of the cella is destroyed partially, is destroyed totally in case of grade 4, and the CSF or blood spread is called grade 5. Okay, based upon this is called Hardy classification. And another one is a NOS classification. Okay, NOS classification is based upon the carotid sinus involvement of the tumor. Before that, we have to know about 3 lines. Okay, 3 important lines. Based upon this, NOS grading is mainly derived. The 3 lines are: one is a medial tangential line, intercarotid line, and lateral tangent line. These 3 lines are based upon the internal carotid arteries. The medial wall of the internal carotid artery in the ICA is medial tangent, and the midline of the carotid is intercarotid, and the lateral part of the carotid is called lateral tangent. Okay, so whenever the pituitary adenoma is medial to that medial tangent line is 0. Okay, between the medial tangent and the intercarotid is grade 1, and beyond the between the intercarotid and the lateral tangent is grade 2. Okay, and the grade 3. Grade 3 is beyond the lateral tangential line. The grade 3 is again divided to 3A and 3B. The 3 is superior cavernous sinus involvement, and the B is the inferior cavernous sinus compartment. Okay, and the 4 is complete encasement of the ICA. These are the pituitary adenoma classification. So, the 0, the tumor does not cross lateral to the MLL. So, medial tangential line, that is called ML. So, the tumor crosses MLL, but not crossing intercarotid line. The tumor crosses the grade 2. The grade 2 is the tumor crosses MNL, intercarotid, but not lateral. Okay, so 3A and 3B. Okay, 3 is above ICA, superior compartment. 3B is below the ICA, inferior compartment. So it is lateral. Both of the tumors lateral to the LL, and the 4 is complete enhancement of ICA. This is simple classification, NOS classification. Okay, and you have seen the Hardy's classification, modified Hardy classification. And what are the basic pre-op workup for the pituitary tumors when the patient presents with pituitary tumors? So evaluation, first you have to complete ophthalmic evaluation, especially visual field chart. You have to put the visual field chart. Okay, okay. If the most common presentation, when the tumor compress optic chiasm, it leads to the bitemporal hemianopia. Okay, under the other endocrinological test, what the endocrinological test you have to do is, you have to do serum cortisol, okay, thyroid function test, prolactin, and a gonadotropin test, FSH, LH, okay, and the insulin-like growth factor, IGF-1, and fasting blood glucose. Okay, this is very important. And a radiological examination, doing MRI pituitary protocol. Okay, MRI, mainly you have to do with the MRI brain pituitary protocol is a test of choice. Okay, okay. So ophthal evaluation, endocrine evaluation, and a radiological evaluation. You have to do before going for a surgery for the starting treatment for the pituitary SOL. Okay, so it's very important. Ophthal, endocrine, and the radiological. Okay, the ophthal you have to do the visual field chart, and in endocrine you have to do the endocrinological test like various hormonal tests like prolactin, growth hormone, gonadotropin hormones. Okay, the IGF-1 and the cortisols, thyroid function test, and the glucose value. Radiologically, MRI brain pituitary protocol is very important. Suppose if MRI is contraindicated, you have to go with the CT with or without contrast. Okay, with the cerebral angio. Okay, and you have to do, apart from MRI, you have to do CT PNS to rule out the bony anatomy, especially the sphenoid sinus anatomy. Okay, it is useful in the management of when we go for the transpinal approach. And the prolactin level, the normal prolactin level for a non-pregnant female is 3 to 30 nanogram per ml. Okay, whenever there is a moderate elevation, that is 22 to 150, it can be a stalk effect. Okay, the stalk effect. Okay, so you should not immediately start the medications. The patient may be present in the stalk effect. You have to do the stalk effect. Okay, 25 to 50. Whenever there is more than 150, the patient suffering from the prolactinoma. Okay, so the more than 150 nanogram per ml should be considered as a prolactinoma. By the treatment options, if there is no deficit, you have to go with the dopamine agonist, bromocriptine or cabergoline should be used. Unstable deficit, if the deficit is present, okay, or if the tumor does not respond to dopamine agonist, you have to debulk the tumor and re-challenge with the dopamine agonist therapy. So, surgical indications for prolactinomas. What are the various surgical indications for prolactinomas? For microprolactinomas, do surgery whenever there is a resistance or suboptimal response to dopamine agonist therapy. Okay. Number 2 is intolerance to dopamine agonist therapy. Number 3 is patient's preference to avoid long-term complications. One is resistance, intolerance, complications. Okay. Complications of the dopamine agonist therapy we have to avoid, so that the patient will prefer surgery in case of microprolactinoma. In case of macroprolactinoma, whenever the patient will pituitary apoptosis, you have to do immediately surgery. Cystic prolactinoma, again same resistance, okay, and reduction of the tumor burden, okay, as an adjuvant to enhancing the effectiveness of the dopamine agonist. To enhance the drug effectiveness, you have to reduce the tumor burden, okay, for the purpose of by using radiotherapy tumor like that. Tumor with the extensive erosion of the sphenoid sinus, okay, or high risk of CSF leak with the dopamine agonist, okay, induced due to tumor shrinkage by the dopamine agonist, the patient develop more risk of CSF fluid leak, okay. So, in female desiring pregnancy, to reduce the eventual risk of for pregnancy induced tumor enlargement, okay, so that the patient will take a surgery, go for surgery. Mass effect manifesting during pregnancy, or uncertainty of prolactinoma diagnosis, or we need the tissue diagnosis to evident it as a prolactinoma. That case you have to go for a surgery. These are the various indications, surgical indications of prolactinoma, especially in case of microprolactinoma and macroprolactinoma. So, microprolactinoma, when the patient is resistance, tolerance, or avoid long-term complaints, you have to go for surgery. Macroprolactinoma, pituitary apoplexy, cystic prolactinomas, and resistance or suboptimal response to dopamine agonist therapy, or you have to reduce the tumor burden to increase effectiveness of the dopamine agonist therapy. Whenever the sphenoid sinus is eroded very aggressively, to avoid a CSF leak, you have to go for a surgery. And the patients desiring for pregnancy, that time we can go for surgery. During pregnancy, if pituitary mass develops, we can go for surgery. Okay. Whenever there is uncertainty of diagnosis, you can do surgery. What are surgical approaches for pituitary tumors? Okay. We have 3 approaches. One is transsphenoidal, transcranial, and skull base approaches. Okay. The transsphenoidal can use endonasal, okay, or sublabial, okay. In endonasal, we can use endonasal, submucosal, transseptal, transsphenoidal approach, endonasal, submucosal, septal pushover approach, and another sublabial, transseptal, transsphenoidal approach, and another is a endoscopic transsphenoidal approach. Okay, there are various transsphenoidal approaches. There is standard transcranial approaches is frontoorbital craniotomy, frontotemporal craniotomy, subfrontal craniotomy, bifrontal craniotomy, temporal craniotomy, and supraorbital keyhole craniotomy. These are the various options of transcranial approach. And skull base approaches like cranio-orbitozygomatic approach, transfetrosal approach, and extended transsphenoidal approach. For the various indication for transcranial approach, whenever the patient having a cottage low flake tumors, that is minimal enlargement of the cella with a large supracellular mass, okay, especially if the diaphragmatic cella is tightly constricting the tumor, okay, and the supracellular tumor is causing chiasmal compression, we have to go for transcranial approach, okay. So, this is the tumor, is the cella, the diaphragmatic cella, diaphragm of the cella. Whenever the tumor is, and the diaphragmatic cella compressing the tumor, and it will look like a cottage loaf, and it is compressing the optic chiasm, okay. By the time we can go for the big tumor, we can go for transcranial approach, okay. Whenever the tumor extends to the middle fossa, okay, we can go for open surgery, okay. Unrelated pathology which may complicate a transcranial approach, that is example paracellular aneurysm. Okay, suspecting of any paracellular aneurysm, that time to avoid the aneurysmal bleed, you can go for transcranial approach. An unusually fibrous tumor that could not be removed completely, Okay, suppose the previous patient underwent a previous transprenal approach, the pathway is very fibrotic, so you can go for a transcranial approach only, and the recurrent tumor following transsphenoidal resection. So this is a various indication for transcranial approaches. One is cotton-loaf tumor, tumor extended to the middle fossa, unrelated pathology, unusually fibrous tumors on a previous transprenal approach tumors, and a transprenal resection, recurrent tumors. What is pituitary aplaxy? This is a syndrome associated with the hemorrhage or infarction in a pituitary tumor. Okay, it is a very emergent condition. The patient present with a sudden headache, visual loss, ophthalmoplegia, with or without impaired conscious level. The endocrine resuscitation with the IV steroids is the main line of management. Okay, you should not directly take the patient to the surgery. First, you have to medically resuscitate the patient with the IV steroids, the endocrine resuscitations. Okay, followed by surgical decompression if needed, we can do. Mr. XY is at a 65-year-old male presented with the hearing loss. Okay, which is more in the left side than the right side for 3 months, tinnitus, unsteadiness while walking, and left-sided facial numbness. Okay, on examination, the patient having bilateral sensory hearing loss, ataxia, decreased sensation on left-sided cranial nerve 5, 1, 2, 3 areas. Okay, and it's involved cranial nerve 5, 8, and cerebellum. Okay, that is, okay, it involves cranial nerve trigeminal, vestibulocochlear, and cerebellum. So, what is the diagnosis? So, this MRI, there is a T1 weighted MRI, it shows a well-defined hypertense lesion in the bilateral CP angle region. Okay, so it is typically a bilateral CP angle SOL. Okay, so the most common CP angle SOL, the bilateral involvement, it is a bilateral vestibular schwannoma. Okay, the diagnosis should be a bilateral vestibular schwannoma, and it is belong to a syndrome. What syndrome? Neurofibromatosis type 2. Okay, it is a syndrome belongs to. What is the criteria for the syndrome? Okay, what are the criteria for NF2? What is the triad? Okay, and treatment. Okay, so this is a neurofibromatosis type 2. So the answer is bilateral CP angle SOL. Okay, especially the most common CP angle SOL is a bilateral vestibular schwannoma. Okay, based upon the history also, the patient having the typical triad of hearing loss, tinnitus, and loss of balance, which is particular to the vestibular schwannoma, and a syndrome associated with NF2. What is the criteria for NF2 is Manchester criteria for NF2. Triad is, one is hearing loss, tinnitus, third is loss of balance, and differential diagnosis of this condition is meningioma and epidermolysis. What is Manchester criteria for neurofibromatosis 2? One is bilateral vestibular schwannoma. If it is there, it is confirmed. Okay, the patient suffering from NF2 or first degree relative. Okay, with unilateral vestibular schwannoma. Okay, or any two of meningioma, schwannoma, glioma, or cataract, especially posterior subscapular cataract. Okay. Okay. So so bilateral schwannoma, if it is there, it is confirmed. It is NF2. If it is not there, if one first degree relative with the unilateral vestibular schwannoma or any of two of the following, that is meningioma, schwannoma, glioma, or posterior subscapular cataract. Okay, if it is there, any two, that is belongs to NF2. Third criteria is unilateral vestibular schwannoma, with any of two, any two. Okay, any two of the above case. Okay, meningioma, schwannoma, glioma, posterior subscapular cataract. If it is there, that is also NF2. Okay, whenever you have a multiple meningioma, okay, with unilateral vestibular schwannoma or any two of ependymoma, schwannoma, or cataract. Okay, that is also an F2. Okay, there are 4 points in the criteria. One is bilateral vestibular schwannoma. Okay, second is first degree relative with the unilateral vestibular schwannoma or any 2 of the following: meningioma, schwannoma, glioma, cataract, or unilateral vestibular schwannoma with any 2 of meningioma, schwannoma, glioma, or cataract, or multiple meningioma with unilateral vestibular schwannoma or any 2 of the following: ependymoma, schwannoma, postsubscapular cataract. The treatment, whenever you have is based upon the size of the, this is general management protocol for the vestibular schwannoma, not for NF2. Okay. So, general is a small intracranicular tumor. Okay, within the intra-aortic canal, managed with the surveillance, asymptomatic, you can go for surveillance. For intermediate size, you can opt for radiosurgery. Okay. Whenever the lesion is more than 4 centimeter, especially with the brainstem compression, we can do excision. Okay. In case the patient having hydrocephalus, we can consider VP shunt also. So, indication for size is more than 4 centimeter. Patient with a larger tumor, but typically having no serviceable, okay, hearing. Okay, we can't be able to preserve his hearing. Then you have to focus on preserving the facial nerve preservation. At least you have to prevent the facial other nerve near to it, the facial nerve. This is a bilateral vestibular schwannoma, belongs to NF2. So, this is a Manchester criteria for NF2. And various treatment options. Next, a newborn baby presented with swelling at back with the paraplegia and leg deformity. Okay, it's a typical direct question. So, the newborn baby having a well-defined swelling, this is a cystic fluctuation in the back with the paraplegia. So, the diagnosis should be, it's a case of neural tube defect. Okay, it is a spina bifida. Okay, spina bifida apparata because it is opened. Okay. The various types, risk factors, and ideal timing for the surgery and related complications. So, the diagnosis, neural tube defect is a spina bifida apparata, is a case of myelomeningocele. Okay, the spina various types of the neural tube defect, the spina bifida occulta and spina bifida apparata. So, occulta is closed. Okay, and apparata is opened. Okay, like myelomeningocele is pouching out. Okay. Apparata is pouching out, occulta is within the surface. Okay, it will not outpouched outside. Okay, it's occulta, and apparata is outpouched outside like meningocele, myelomeningocele. Okay, what is the embryological reasons? Is a failure of the closure of the neural tube defect due to the risk factors like folate deficiency. The mother didn't take the folic acid during the pregnancy. The family history, usage of certain anticonvulsant drugs, or syndromic involvement like Arnold-Chiari malformation 2. Okay, where the involvement of myelomeningocele, and 24 to ideal timing of surgery is 24 to 36 hours of the birth. What are the late complications of this myelomeningocele? Repair also. Okay, the patient present with the hydrocephalus. In case the patient is belongs to Arnold-Chiari 2 also, and due to the adhesions of the CSF circulations, obstruction of the CSF circulation, the patient develop hydrocephalus. Okay, and second is a syrinx. Okay, and third is a tethered cord. Number 4th is a chariot. If the patient belongs to a chariot 2 malformation, they compress the medulla. It's called medullary compression due to the chariot 2 malformation. Next, a newborn preterm baby delivered by a C-section. Okay, not by a normal delivery, is delivered by a C-section, is presented with a swelling at the back of the skull like this. Okay, so what is the diagnosis? Types, what is the embryological reasons behind this? Okay, so this is a cystic swelling that is seen in the occipital region. Okay, it's called occipital encephalocele. Occipital encephalocele, it is mainly due to the defective closure of cranial neuropores. So, embryological reasons. So, usually the anterior cranial neuropores are closed at 25 days, the posterior cranial neuropores closes at 28 days. 28 days of the life, but it is not closed, it is called, it will defect due to defect of encephalocele. Various types of encephaloceles: occipital, syncypital, convexity, basal. Okay, syncypital is again classified into frontoethmoidal, interfrontal, and associated with the craniofacial clefts. Okay, the frontoethmoidal encephaloceles is classified again into nasofrontal, nasoethmoidal, nasoorbital. So what are the various, again the types? Okay, occipital, it's a cranial vault, okay, which is more common in the Western countries. Okay, occipital is more common in the Asian countries. Okay, so the cranial vault again divides into interfrontal, anterior fontanelle, interparietal, temporal, posterior fontanelle, and the sincipital. Okay, sincipital, the external opening into the face. Okay, in the one of the three regions, the nasofrontal, nasoethmoidal, nasoorbital. Okay, it's also known as frontoethmoidal. Okay, and the basal again divided into transethmoidal, sphenoethmoidal, transsphenoidal, frontosphenoidal, and the posterior fossa. So the encephalocele is embryological reasons and various types. Next, a 2 months old baby is a normal vaginal delivery is presented with the abnormal shaped head to the OPD by his mother. Okay. So what is the diagnosis? Types, various types of this condition. What are syndromes involved in these types? What is surgery of choice? Okay. So the diagnosis, it is a premature fusion of the skull sutures, that is called craniosynostosis. Okay. So that in the craniosynostosis, it's a craniosynostosis. So it belongs to scapulocephali due to the abnormal closure, due to the premature closure of the sagittal sutures. Okay, and the picture shows it shows like a boat shaped. Okay, boat shaped skull. Okay, what are the types of craniosynostosis? Scapulocephali, brachycephaly, microcephaly, plagiocephaly, and trigonocephaly. So scapulocephali is mainly due to the sutures involved the sagittal sutures, and the brachycephaly is coronal sutures. Okay, and the microcephaly all sutures are involved, and the plagiocephaly is unilateral. Unilateral coronal with the lambdoid. Okay, unilateral coronal with the lambdoid is plagiocephaly, and metaphysic suture is a trigonocephaly. So the clinical features, whenever the skull look like a narrow boat like, it is scapulocephaly. Okay, whenever the patient having a shortened forehead is coronal due to the involvement of the coronal suture, that is called brachycephaly. Okay, whenever the microcephaly shows overall small head is brachycephaly, is microcephaly, and asymmetrical skull is due to the involvement of the unilateral sutures. Okay, it's called plagiocephaly, and trigonocephaly is a pointed narrow head. Okay, it's called metaphysic suture. There are various syndromes involved. Clinical craniosynostosis is most common is Eppert, Croson, Pfeiffer, Jackson-Weiss, okay, and A3 Zorsen syndrome. Okay, A3 Zorsen syndrome, and the main mode of surgery for this patient is you have to go for a strip craniectomy. Okay, you have to remove the strip of the cranium. Okay, strip of the cranium along with the suture. Okay, in order to make the brain to develop. Okay, so craniosynostosis, a case of craniosynostosis. Next, a 5-year-old male child presented with a severe headache with neck pain and weakness and numbness of the limbs. The same child is also having the history of myelomeningocele in the past, which is operated in the newborn. Okay. Okay, what is the diagnosis? Types. Okay, and differences between various types and surgery for this patient. So this child is typically evident to the herniation of the cerebral tonsil. Okay, and the child may also have syrinx in the spinal canal. Okay, so syrinx, cerebral tonsil descent. So the diagnosis is belongs to Arnold-Chiari type 2 malformation. The various types 1, 2, 3, 4. Okay, 4 main types are there, apart from certain uncertain types also there. So the type 1 is tonsorial hernial more than 5 mm inferior to the plane of the foramen magnum, that is Bayesian-Opisthian line. Okay, it is a Bayesian-Opisthian line. The Bayesian-Opisthian line is, it is a Bayesian. The posterior bar of the foramen magnum is the Bayesian. So this is the Opisthian. The connecting these two lines is the Bayesian-Opisthian lines. Whenever the herniation of this foramen magnum below this line, it is called descent of the hernia. Okay, descent of the cerebellar tonsil. Okay, so whenever the tonsillar herniation more than 5 mm inferior to the plane of the foramen magnum, that is a basal piston line, and no associated brainstem herniation or supratentorial anomalies, and hydrocephalus is uncommon, but syringomelia is common in type 1. Okay, these are the type 1. The type 2, the same herniation of the cerebellar vermis with the brainstem, okay, and the fourth ventricle. Extra brainstem, fourth ventricle also involved in the herniation. It is associated with the myelomeningocele, okay, most of the times, and multiple brain anomalies. Okay, so hydrocephalus and syringomelia also very common in Chiari malformation type 2. Okay, that's why the patient had a history of myelomeningocele repaired in the childhood stage. Okay, and the hydrocephalus number grade 3. Okay, grade 3 is high cervical or occipital encephalocele. The patient presented with the occipital encephalocele. Okay, along with the herniated cerebellar brainstem tissue. Okay, when you have noticed aplasia or hypoplasia of the cerebellum, it is called grade 4. Okay, so here only is cerebellar descent only with the syringomelia. Okay, cerebellar tonsillar descent more than 5 mm. Okay, here cerebellum, brainstem, and grade 2 ventricle, fourth ventricle. Okay, here syringomelia also common, and more associated with the myelomeningocele and hydrocephalus. Grade 3 is associated with occipital encephalocele, and grade 4 is hypoplasia, aplasia or hypoplasia of cerebellum. So what are the other types present in the history is Chiari type 0, type 0.5, type 1.5. Type 0 is only syringohydromelia, okay, without hindbrain herniation. Okay, that is response to the posterior fossa decompression, and 0.05 is less than 5 mm. It is more than 5 mm. It is called Chiari type malformation 1. If it less than 0.5 mm, 5 mm is 0.5 centimeter, or 5 mm is Chiari type 0.5. Okay, what is Chiari type 1.5? It is a severe form of Chiari 1. Okay, the entire cervicomedullary junction, including the abscess of the cerebellum, is situated below the foramen magnum. Okay, it's also associated with the condition called platybasia. Okay, where is the skull base is flattened. Okay, okay, platybasia with the severe form of cervicomedullary descent. Okay, it responds to the suboccipital decompression. Okay, like Chiari 1, but with the exception that the syringomelia will persist. Okay, so what is a common surgery undergone for Untitled malformation is foramen magnum decompression with lax neuroplasty. Okay, we can go for lax neuroplasty. Can remove the foramen magnum, part of foramen magnum behind the skull. Okay, that is a posterior fossa, and you have to place a neuroplasty using that dural substitutes. Okay, dural substitutes like gallia you can use. Okay, pericranium, or you can use even that tensor fascial lata also you can use for the dural substitutes. Okay, so Arnold-Chiari malformation, okay, various types and surgery. Thank you.